Welcome back to the deep dive. Um, Today, we are actually walking right past the gleaming, highly automated rows of the bacteriology lab.
Yeah, we're completely ignoring them.
Right, ignoring the hum of the mass spectrometers, ignoring the robotic arms plating samples. We are heading into the back corner, the dusty corner where the lights are just a little bit dimmer and the smell of chemicals is definitely a little sharper. We're putting on the deerstalker hats. We are entering the Sherlock Holmes sector of microbiology.
I mean, that is really the perfect analogy. Because in modern medicine, we're incredibly spoiled by automation.
Oh, absolutely.
You have a patient with sepsis, you put a blood bottle in a machine, and literally 6 hours later, it beeps, tells you it's E. coli, and even tells you exactly what drugs will kill it. It's almost push-button medicine at this point.
Right.
But the topic we are covering today, parasitology, it completely refuses to be that simple. It is still a very manual, visual, and incredibly clinical craft. It relies entirely on the human eye and the human brain.
It really feels like the last bastion of the artisan in the hospital lab.
Hmm.
And to guide us through this, we are cracking open the heavy artillery today. We're using Chapter 70 of Murray's Medical Microbiology, 9th edition. That is going to be our structural spine for this deep dive.
Correct. Murray Chapter 70, which is titled Laboratory Diagnosis of Parasitic Disease, is our roadmap. But to make this truly three-dimensional for you listening, we are going to layer in some vital visual details from Jawet, specifically chapters 46 and 47.
Yeah, because we need those visuals.
Exactly. Because unlike bacteria, which, they often just look like generic rods or little spheres, parasites have personality. They have actual faces. You cannot diagnose what you can't visualize.
So, what is our mission here? Because for most people, and honestly, I mean, even many doctors, the mental model for diagnosing a parasite is basically just, patient has tummy trouble, send a stool sample in a plastic cup, and hope the lab finds a worm.
Yeah, that is the search and hope strategy. And frankly, it's a disaster. It's terrible medicine. Our mission today is to completely replace that with a search and rescue mental model.
Search and rescue, I like that.
We need to understand diagnosis by sight. Like, is it in the stool, is it in the blood, or is it deep in the tissue? And we have to understand it by method. Are we using a microscope? Are we using antigen detection? Or are we going straight to molecular DNA testing? We are basically going to turn that giant wall of text in Murray about specimen collection into a very logical decision tree for you.
Okay, let's start with the mindset then. Because Murray opens this chapter with a pretty significant warning about clinical symptoms. He essentially says you cannot trust them, which feels a bit harsh for the clinicians out there trying to do their jobs.
It might feel harsh, but it is incredibly accurate. Murray makes a strong point that clinical manifestations of parasitic diseases are rarely specific. If a patient walks into the clinic with a fever, some malaise, and diarrhea,
that could literally be anything.
Oh, exactly. It could be a virus, it could be a bacteria, it could be a parasite, or they just ate some bad sushi. There is no glowing neon sign above their head that says parasite here.
Wait, I actually have to challenge that immediately.
Yeah.
Because what about eosinophilia? A high eosinophil count in the complete blood count. That is the classic, absolute gold standard board exam clue for parasite. If I see high eosinophils, my brain immediately thinks worms.
Okay, it is the classic clue, yes, but it is a very dangerous crutch in the real world. Murray is very specific here, and this is a massive high-yield differentiator for you to remember. Eosinophilia is generally associated with helminth infections, so worms. And specifically, it peaks when those worms are migrating through human tissue.
Okay, so tissue migration triggers the eosinophils.
Right. But it is very often completely absent in protozoan infections. You can have a raging, life-threatening case of malaria or giardia or amoebiasis, all of which are protozoa and have totally, completely normal eosinophil levels.
Wow. So if you just hang your hat on that one single lab value,
you will miss half the diagnoses in the textbook. You'll send a patient home with Tylenol when they actually have falciparum malaria.
Man. So we really can't rely on the automated blood count to flag us down.
Yeah.
Which leads us to what you call the holy trinity of diagnosis. If the machine isn't going to wave a red flag, what actually will?
Since the machine won't save you, you need these three pillars. The first pillar is physician suspicion. You have to actually think of the disease. This is not a routine screening panel. This means actually doing your job and digging into the travel history, the food intake, the socioeconomic status. Did they go camping? Did they eat raw freshwater crab? Have they been walking barefoot in soil?
You have to be the detective before the lab even gets involved. And the second pillar?
The second is specimen quality. In parasitology, the phrase garbage in, garbage out is not a cliche. It is a literal law of physics. If you send a dried out, 2-day-old sample, the lab finds nothing.
Makes sense. And the third?
Third is lab competence.
That one is really interesting because Murray strongly implies that not all microbiology labs are created equal when it comes to this stuff.
He is quite blunt about it, honestly. He explicitly says it is much better for a laboratory to offer a very limited menu of well-performed tests than a huge, comprehensive menu of poorly performed ones.
Jack of all trades, master of none.
Right. Because parasitology relies heavily on morphology, recognizing tiny, subtle shapes and patterns. If a lab tech only sees a malaria blood smear, maybe once a year, they are incredibly likely to mistake a clumped platelet for a parasite or some stain artifact for a deadly amoeba. It requires constant, repetitive practice. It's a volume game. If you don't see it regularly, you lose the eye for it.
Okay, so that perfectly sets the stage. Now, before we actually get into the stool cups and the blood smears, we need to establish a core conceptual anchor that I think trips up almost everyone learning this. You call it the life cycle as a clock.
Yes. This is the single most critical concept for you, the listener, to grasp today. Bacteriology is usually three-dimensional. You just ask, where is the infection? Is it in the lung? Is it in the bladder? But parasitology is four-dimensional. You have to consider time.
Time. Because these organisms moving around.
Because they migrate through the body, and they have distinct rhythms. They follow a circadian rhythm just like you and I do. If you do not intimately understand the life cycle, you will be looking for the wrong thing at the completely wrong time. The absolute classic example Murray uses to illustrate this is filariasis, specifically the nematode Wuchereria bancrofti.
Okay, Wuchereria bancrofti. This is the nematode that causes elephantiasis, right? The one that blocks up the lymph nodes and causes that massive, disfiguring swelling in the legs.
Exactly. The adult worms live deep inside the lymphatic system, but they release their offspring, which are called microfilariae, out into the peripheral blood so they can get picked up by the next host. But here's the biological trick. Wuchereria bancrofti has what we call nocturnal periodicity.
Meaning they only commute at night.
Yes, it is a brilliant evolutionary adaptation. The vector for this parasite is a specific mosquito that only bites at night. So the microfilariae literally surge into the peripheral bloodstream between 10 p.m. and 4 a.m. to perfectly match the mosquito's feeding schedule.
That is wild. Where are they during the day?
During the day, they retreat and hide deep in the pulmonary capillaries, the lung capillaries, where you cannot possibly reach them with a standard venous blood draw.
Okay, so think about the clinical implication of that. If a doctor on morning rounds draws blood at, say, noon,
the blood is completely clean. You will find absolutely nothing. You will confidently rule out the disease falsely simply because you ignored the clock. To get the diagnosis, you literally have to wake the patient up at 2 in the morning to draw the blood.
Wow.
Now contrast that with Loa loa, the African eyeworm. It has a different vector, a chrysops fly that bites during the day. So Loa loa is diurnal. You have to bleed that patient right around noon to catch it.
So the biological clock directly dictates the medical test.
That is fascinating. What about the actual form of the parasite? Because I feel like that trips people up constantly. We are so used to looking for the bug, but these bugs literally change shape.
It is a massive stumbling block. Let's look at Strongyloides stercoralis. This is a very important intestinal nematode. Now, for almost every other intestinal worm, like Ascaris, which is the giant roundworm or hookworm or whipworm, we are trained to look for eggs in the stool.
Right. You scan the microscope slide looking for that classic oval shape of an egg. That's the gold standard ONP.
If you do that exact same thing for strongyloids, you will fail. Because strongyloids' eggs actually hatch inside the bowel wall. They almost never make it out into the stool intact. What actually comes out in the feces are the larvae, the little baby worms, specifically the rhabditiform larva.
So for strongyloids, the diagnostic form is the larva, not the egg.
Precisely. If your mental filter is rigidly set to find eggs, you will look right past the wriggling worm and call the sample negative. That is a crucial testable distinction. Ascaris equals eggs. Strongyloids equals larvae. And it is entirely a function of where the physiological hatching happens.
Exactly. Diagnosis is just applied biology. You cannot separate the laboratory test from the organism's life cycle.
All right, let's descend into the most common and frankly the least glamorous part of this job. The stool exam. Section 2. The famous O&P Ovan parasite exam.
It is the bread and butter of the parasitology lab. Stool is the primary specimen for all intestinal parasites. But Murray lays down a very strict evidence-based protocol here, which is universally known as the rule of 3.
Yeah, I've seen this exact order set in the hospital computer systems. Stool O&P times 3. Why 3? Is the test itself really that bad? Why can't we just get it right the first time we look?
It's not that the microscopy is bad, it's that the parasites themselves are incredibly inconsistent. They shed intermittently. They are not at all like bacteria, which are just constantly dividing and always present in the gut lumen. Parasites release their eggs or their cysts in bursts or cycles. Murray cites some data on this that I think is really eye-opening for clinicians.
Let's hear it.
A single one-off stool specimen detects only about 50% to maybe 71% of active infections.
That is basically a coin flip. If I only send one sample down to the lab, I am missing a third to a half of all positive cases. That is a terrifyingly low sensitivity for a major diagnostic test.
It really is. But if you collect 3 separate specimens, the detection rate jumps up to almost 100%. The math is just undeniable there. So the rigid protocol is to collect 3 specimens over a period of usually 7 to 10 days. And crucially, they must be collected on alternate days.
Why alternate days, though? Why can't the patient just fill 3 different cups on a Monday morning and get it over with?
Because of that intermittent shedding cycle, if you collect 3 samples from the exact same bowel movement, or even just from the same morning, you are essentially sampling the exact same batch of stool. You aren't increasing your temporal spread at all. You want to sample on Monday, then Wednesday, then Friday. You need to cast a wide enough net over time to catch a shedding cycle.
Okay, scientifically that makes perfect sense, but logistically that is a really heavy lift for an outpatient. Here, please take these 3 plastic containers, put your stool in them, and keep them in your refrigerator next to the milk for a week.
Oh, it is an absolute compliance nightmare. Patients hate it. But it is literally the only way to get true diagnostic sensitivity. If you only send one, you simply cannot confidently rule out a parasite. Now, beyond compliance, there are also what we call deal breakers, things that absolutely ruin the sample completely.
The do not collect list. What's on it?
Top of the list by far, barium. If a patient has recently had a barium swallow or a barium enema for a radiology scan, you are completely out of luck. Barium is chalky, it's bright white, and it is incredibly dense. It physically, optically obscures the microscopy.
You just can't see through it.
You can't see a semi-transparent amoeba cyst through a solid wall of white chalk. Murray says you have to wait at least 5 to 10 days for that barium to naturally clear the GI tract before you can even attempt an O&P.
It's like trying to find a clear contact lens dropped into a glass of whole milk.
That's exactly what it looks like under the scope. The other big deal breaker is recent antibiotics, specifically things like tetracyclines or anti-malarial drugs. You generally need to wait a full 2 weeks after those medications are stopped.
Now, antibiotics, I understand if we're looking for a bacterial infection. But why do they mess up a search for a eukaryotic parasite?
2 main reasons. First, some antibiotics actually have incidental, mild antiparasitic activity. They might temporarily stun the organism or just reduce the total numbers below our visual detection threshold without actually curing the infection.
So it's a false negative.
Right. And second, for protozoa like entamoeba, they literally feed on the ambient gut bacteria. If you wipe out the normal bacterial flora with a broad-spectrum antibiotic, the protozoa starve. So they immediately insist that they form their hard protective shells, making them much harder to find and identify. You've completely altered their ecosystem.
Fascinating. Now, there's a very specific rule Murray mentions that I want to highlight. It's called the hospital rule, or the 3-day rule. This is a massive one for anyone listening who works in a hospital setting. I vividly remember getting yelled at by a lab tech during my residency for violating this.
Yes, this is a major diagnostic stewardship point. Stool O&P testing is generally considered entirely inappropriate for patients with hospital-acquired diarrhea.
And hospital-acquired is defined as diarrhea starting more than 3 days, so 72 hours after admission.
Correct. Because if you have been sitting in a hospital bed for 4 days, eating hospital food, and suddenly you get the runs, you absolutely did not catch Giardia from the nursing station.
Right.
Parasites have incubation periods. If the diarrhea starts on day 4 of an admission, it is almost never a parasite. It is overwhelmingly likely to be Clostridioides difficile or a medication side effect or just tube feeding intolerance. Laboratories often have a hard stop policy programmed into their systems. If the admission date was 4 days ago, they will automatically reject the O&P order unless there is a very specific manual override.
Like if the patient is severely HIV positive or maybe an actual suspected hospital outbreak of something.
Exactly. But otherwise, it just wastes money and vital lab tech time.
Okay, let's talk about the physical sample itself. We have the cup, we have the specimen, what actually happens to it.
Again, the biology dictates the handling. This heavily depends on the physical consistency of the stool. If the stool is purely liquid, it implies a very rapid transit time through the gut. Things are moving fast. Therefore, the parasitic forms most likely to be present in that liquid are the trophozoites.
Let's clearly define that for the listeners. Trophozoite.
It comes from the Greek root troph, meaning to feed or nourish. Trophozoites are the active, feeding, multiplying motile stage of the protozoa, and they are incredibly delicate. They're basically just a fragile cell membrane holding some cytoplasm together. If they cool down to room temperature, or if they dry out even slightly, they die. Or they do what we call roundup.
Roundup.
Yes, within 30 minutes of leaving the body, they lose their distinct shapes and just become generic circular blobs. And once they round up, you absolutely cannot identify them.
So a liquid stool specimen is essentially a stat lab order.
It has to be treated as one. It must be physically examined under the microscope within 30 minutes of collection, or it must be placed immediately into a chemical preservative like PVA, which is polyvinyl alcohol, or 10% formalin. If a nurse leaves a liquid stool cup sitting on the counter for 2 hours while they go on a lunch break, the evidence is entirely destroyed.
What about formed, solid stool?
Formed stool usually contains cysts. Because the stool moves slowly through the colon, the parasite had time to prepare for the outside world. Cysts are the dormant, hardy, highly infectious stage. They have a very thick protective wall, so they can survive much longer outside the body, hours or even days, depending on the conditions. So you have a lot more breathing room with a solid sample. But even then, getting into preservative quickly is always best practice.
All right, the sample is securely in the lab. It hasn't been ruined. Now we enter section 3. The 3-step stool analysis, the actual search and rescue operation. Murray outlines this very specific protocol. It's definitely not just smear it on a slide and look at it.
No, it is a highly regimented protocol. Step 1 is the direct wet mount. You take a tiny, tiny bit of the fresh stool, you mix it with a drop of physiological saline on a glass slide, put a cover slip over it, and you look.
And what is the primary target for step 1?
Motility. This is the one and only step in the entire process where you can actually see the organism moving around. You are scanning for the tumbling, erratic movement of Giardia, or the purposeful directional swimming of entamoeba trophozoites, or the active wriggling of those strongyloids larvae we talked about.
And you mentioned iodine earlier in relation to this step.
Right, you can and usually do a second wet mount right next to it using a drop of Lugol's iodine. Now, iodine is a double-edged sword. It stains the internal glycogen and the nuclei, so it makes the internal structures really pop visually, but the iodine kills the organism instantly.
So you lose the motility.
Exactly. So the rule is saline to see the movement, iodine to see the internal structure.
Got it. Step 2 of the protocol is concentration.
Think of this step as the sieve. In a mild or light infection, there might be very few actual parasites swimming in an absolute sea of normal fecal debris and bacteria. If you just look at a direct smear, you'll likely miss them entirely. We have to separate the gold, the diagnostic cysts and eggs from the dirt.
And how do we break the laws of physics to actually separate them out?
We exploit specific gravity. The two main laboratory methods are formalin ethyl acetate sedimentation and zinc sulfate flotation.
Flotation makes intuitive sense.
Yeah.
You use a heavy liquid, and the lighter parasite eggs just float to the top.
That's exactly the mechanism. Zinc sulfate is a very heavy, dense salt solution. The parasite eggs and cysts have a lower specific gravity, so they are lighter than the fluid. They literally float to the very top surface meniscus, and the tech just scoops them right off the top with a wire loop.
And sedimentation is the opposite.
Right. Sedimentation is the reverse process. You use ethyl acetate to dissolve away the fats and the fecal debris, and then you centrifuge it hard. So the heavy parasites are driven down and end up concentrated in a tiny pellet at the very bottom of the tube. Honestly, sedimentation is generally the preferred method globally because it reliably recovers everything. Flotation can actually miss some of the heavier eggs, like schistosoma, which will just sink right to the bottom and be missed.
Okay, so now we have our concentrated sample. We have effectively found the needle in the haystack. What is step 3?
Step 3 is the permanent stain. I like to call this the mugshot. This step is absolutely non-negotiable for identifying protozoa. We typically use stains like trichrome or iron hematoxylin.
Why is this final step so essential? I mean, couldn't we just identify them from that concentrated iodine wet mount?
Not reliably, and definitely not safely. Remember, a lot of these amoebas look nearly identical under a standard wet mount. Let's take Entamoeba. Entamoeba histolytica is a ruthless killer. It causes severe, bloody dysentery and massive liver abscesses. But Entamoeba coli, same genus, completely different species, is just a friendly, harmless, commensal organism. It lives in your gut and does absolutely nothing.
And they look the same size?
They are roughly the exact same size and shape. The critical difference between the killer and the bystander is in the nuclear chromatin, the physical pattern of the DNA arranged inside their nucleus.
And you can only see that level of detail on a permanently stained slide.
Correct. The trichrome stain is beautiful. It colors the background cytoplasm a soft blue-green, but it stains the nuclear chromatin a dark red or purple. That stark contrast allows the tech to clearly count the exact number of nuclei and check the peripheral chromatin ring. It is literally the difference between convicting a murderer and arresting an innocent bystander who just happens to look like him.
Wow. Now, Murray throws a massive red flag right here in the text. A standard O&P exam, even with the trichrome stain, does not detect everything. There are invisible pathogens.
This is a classic board exam trap and a very real critical pitfall that harms patients. A standard trichrome O&P will absolutely not detect Cryptosporidium or Cyclospora.
Wait, why not? They are intestinal protozoa, aren't they?
They are, but they are incredibly small, much smaller than Giardia. And more importantly, they simply do not take up the trichrome stain well at all. On a standard slide, they just look like empty ghosts or generic background debris. If you have a patient with profound watery diarrhea, maybe an immunocompromised HIV patient or someone who just traveled and you suspect crypto, you must explicitly request a modified acid-fast stain.
Acid-fast, just like we use for tuberculosis.
Exactly the same chemical principle. Their oocysts have a tough, waxy outer wall. With a modified acid-fast stain, they retain the carbylfusin dye and stain a brilliant, bright pink or red against a counterstained blue background. If you do not explicitly check the box for acid-fast or order a specific Cryptocyclospora antigen panel, the lab will not do it. They will just run the standard O&P, the report will come back negative, and you will miss a patient who is literally teeming with Cryptosporidium.
That is a huge practice-changing takeaway right there. Standard O&P does not cover the entire waterfront. Let's bring in Jawitz here to really visualize some of these bad guys. If I am the tech looking down the scope, what are my mental anchors? Let's take Giardia lamblia first.
Giardia is totally iconic. It's the poster child. In the wet mount, the trophozoite exhibits what is classically described as falling leaf motility.
Falling leaf.
Yeah, it doesn't swim forward in a straight line. It sort of tumbles and flutters side to side, exactly like a leaf slowly falling from a tree branch.
That is strangely poetic for an organism that causes explosive, foul-smelling diarrhea.
Biology has its weird beauty, even in the bowel. And then on the permanent trichrome stain, the Giardia trophozoite is distinctly pear-shaped. It has two prominent nuclei that look exactly like eyes, and a central axis style running down the middle that looks like a nose. It literally looks like a little clown face, or an old man with glasses staring right back up at you through the microscope. Once you see it, you will never, ever forget it.
That's perfect.
Yeah.
What about Entamoeba histolytica? How do we positively spot the killer amoeba?
The absolute pathognomonic feature for the E. histolytica trophozoa is ingested red blood cells. If you see an amoeba and inside its cytoplasm, you can clearly see intact human red blood cells that it has eaten. That is E. histolytica, period. It is the only intestinal amoeba that actively phagocytoses red blood cells.
So that's the definitive proof of tissue invasion.
Yes. It is literally caught red-handed. If you see that, you don't wait. You start treatment immediately.
Caught red-handed, I love that.
Yeah.
Okay, let's smoothly transition into section 4, intestinal diagnosis beyond the stool cup. Because, frankly, sometimes the parasite just isn't in the poop.
Correct. Let's talk about the pinworm, Enterobius vermicularis. This is the most common helminth infection in the United States, especially rampant in young children.
A classic itchy bottom.
The intensely itchy bottom. So, the adult female worm lives her life mostly in the cecum, but when she's gravid, she has a very specific, strange migration pattern. She crawls all the way down and actually exits out of the anus at night, specifically to lay her thousands of eggs directly onto the perianal skin folds, not in the feces.
So if a pediatrician orders a stool O&P,
you will almost never find them. A stool O&P is a completely useless test for pinworm. You need to order the cellophane tape test, which everyone just calls the Scotch tape test.
how exactly does that work clinically?
It is absolute low-tech genius. You take a piece of standard clear cellophane tape. It cannot be the frosted matte tape. It must be clear. You loop it over the end of a wooden tongue depressor with the sticky side facing out. And you firmly press it right against the perianal skin. The sticky tape lifts the eggs right off the spin. Then you just unroll the tape, stick it flat onto a glass microscope slide, and look at it directly.
And timing is everything here too, right? Just like the blood clock.
Absolutely critical. It must be done first thing in the morning, before the child gets out of bed, before they take a bath, and crucially, before they have a bowel movement. If they bathe or wipe first, you literally wash away the diagnosis.
Good to know.
Yeah.
Okay, moving further up the gut. Sigmoidoscopy. When are we actually using a scope to find a parasite?
This is mostly reserved for suspected Entamoeba histolytica. Sometimes a patient has severe clinical dysentery, blood, and mucus in the stool, but multiple stool ONP exams somehow keep coming back negative. The gastroenterologist will go in with a flexible scope and actually look at the colon wall. They will see these classic pathognomonic flask-shaped ulcers. The neck of the ulcer is narrow at the mucosa, but it balloons out wide deep in the submucosa, like an Erlenmeyer flask.
And do they just take a standard tissue biopsy of that ulcer?
They can, but the better microbiological technique is to scrape the margin of the ulcer, not the dead center, the active edge. You take that mucosal scrape, put it on a slide, and examine it immediately in a saline wet mount. You are hatching for those rapidly moving trophozoites containing the ingested red blood cells we talked about.
Now, talk to me about the string test. Because when I read this in Murray, it sounded like a magic trick or some weird medieval torture device.
The Entero test. It is fascinating. This is specifically for small bowel pathogens that hang on really, really tight to the mucosal wall of the duodenum, mainly Giardia and strongyloids. Sometimes they are holding on so tightly with their adhesive discs that they simply do not shed down into the stool stream in detectable numbers.
So if they won't come out, how do you go in and get them?
You literally go fishing. The patient swallows a specialized gelatin capsule. Tightly coiled inside that capsule is a very long, highly absorbent nylon string. The bitter end of the string is left hanging out of the patient's mouth and gets securely taped to their cheek. The capsule goes down, dissolves in the stomach acids, and the string unwinds. Normal gastric peristalsis carries the weighted end of that string all the way down into the duodenum.
And how long do they just sit there with a string down their throat?
Usually about 4 hours, sometimes overnight, depending on the protocol. The absorbent nylon string soaks up the local duodenal mucus. And because parasites like Giardia live right in that mucus layer, they get physically stuck in the mesh of the string. Then, and this is definitely the unpleasant part, the clinician slowly pulls the entire string back up through the mouth.
Oh, wow. Yeah, that sounds horrible.
It's not great. You pull it out, and then using gloved fingers, you physically strip the bile-stained mucus off the bottom end of the string right onto a glass slide and look at it under the scope. It is a highly effective way to directly sample the deep small intestine without having to schedule an invasive upper endoscopy. But as you can probably imagine, patient enthusiasm for swallowing a string is generally quite low.
I can vividly imagine that. Okay, one last beyond stool scenario here. The liver abscess.
Right, this is an extraintestinal amoebiasis. Remember, E. histolytica doesn't always stay in the colon. It can burrow completely through the gut wall, hit the portal vein circulation, and travel upstream directly into the liver, where it forms a massive, destructive abscess.
So the patient has right upper quadrant pain, a fever, you see a big lesion on the CT scan, you stick a long needle in it and aspirate the pus to find the amoeba.
Right. That is exactly what your intuition tells you to do, and that is exactly why clinicians frequently miss the diagnosis. The center of that abscess is full of what we classically call anchovy paste. It is a thick, reddish-brown fluid made entirely of necrotic, dead, liquefied liver tissue. There are no living, intact amoebas in that central goo.
Because they can't survive in the toxic soup they just created.
Exactly. The living organisms are entirely at the margin. They're at the active feeding front, where the edge of the abscess meets the healthy liver parenchyma. That's where the food is. So if interventional radiology is aspirating this, they have to specifically sample the capsule wall or send the very last part of the aspirate fluid to the lab to find the organisms. If they just send a tube of the central pus, the lab will report it as negative sterile fluid.
That is such a critical clinical pearl. Anchovy paste is dead. Look at the edge. Okay, let's completely leave the GI tract now. We are moving into the bloodstream. Section 5. The malaria protocol.
This is arguably the most high-stakes life-or-death section of the entire chapter. Malaria is a true medical emergency. Plasmodium falciparum can easily kill a healthy, non-immune adult patient within a matter of days if missed. Murray heavily emphasizes that hospital labs must offer 24/7 testing for this. You cannot just leave the sample on the bench and wait for the morning shift parasitologist to clock in.
And the absolute diagnostic gold standard here is ordering the thick and thin blood film. Why do we always need two different smears? Why not just do one good one?
Because they answer two completely different clinical questions. The thick film is entirely about sensitivity. It answers the fundamental question, is there anything actually there at all?
How does making it thicker increase the sensitivity?
You take a very large, fat drop of whole blood, put it on the slide, and use the corner of another slide to stir it around to defibrinate it so it doesn't clot. You let it air dry completely. Then, during the staining process, you use water. That water osmotically lyses. It literally explodes every single red blood cell on the slide.
So all the red cells are just gone.
Gone, washed away. You are left with a highly concentrated soup of just white blood cells, platelets, and hopefully the parasites. It effectively concentrates the blood volume about 20 to 40 times compared to a regular smear. It makes it incredibly easy to quickly spot a very low-level early infection. It's like draining all the water out of an Olympic swimming pool just so you can easily spot a quarter sitting on the bottom.
But because all the red blood cells have been exploded.
You have lost all of your vital context. You can't see the size of the red cell. You can't see the shape. The delicate parasites themselves are often warped and look like little distorted pieces of purple shrapnel. So you can confidently say, yes, this patient has malaria, but you often cannot tell which specific species of Plasmodium it is.
And that is exactly where the thin film comes in.
Precisely. The thin film is all about specificity. It answers the question, which exact species is killing my patient? For the thin film, the red blood cells are chemically fixed with methanol before the stain is applied, so they remain perfectly intact and hold their shape. You can carefully examine the exact relationship between the intracellular parasite and its host cell.
Let's use JAVAs to visualize this differentiation, because this is huge for exams. Why does it clinically matter if it's falciparum versus vivax? Malaria is malaria, right?
Oh, absolutely not. It totally changes the treatment protocol and the patient's prognosis. P. falciparum is the lethal one. It causes microvascular blockages leading to cerebral malaria, kidney failure, and it is highly resistant to standard drugs like chloroquine. P. vivax is thoroughly miserable. It causes terrible fevers, but it is rarely acutely fatal. However, vivax has a sneaky, dormant liver stage called the hypnozoite. You have to give an extra specific drug like primacone just to clear the liver, or they will relapse months later. You absolutely have to tell them apart.
Okay, so I'm looking at the thin film under the microscope. What are my visual clues that scream falciparum?
The absolute biggest neon sign clue is the gametophyte, the sexual stage of the parasite. In falciparum, it is distinctly crescent-shaped or banana-shaped. It stretches the red cell membrane around it. It is entirely pathognomonic. Nothing else in human blood looks like a purple banana.
And what about the earlier stages, the ring stages?
Falciparum is aggressive. You very often see multiple rings crammed into a single red blood cell, sometimes 2 or 3, and they look delicate, like little headphones. You also see the applique form, where the tiny ring parasite looks like a blister stuck on the very outer rim of the red cell membrane. And crucially, biologically, falciparum is not picky. It will infect red blood cells of all ages. Therefore, the infected red cells look like a totally normal size compared to the uninfected ones around them.
Okay, compare that biology to Plasmodium vivax.
Vivax is extremely picky. It only has the receptor to infect young, immature red blood cells, the reticulocytes. Now, because reticulocytes are physically larger than mature red cells, the infected cells on the slide look noticeably enlarged and swollen. And as Vivax grows, it aggressively alters the red cell membrane, causing it to develop this stippling of tiny pink dots all over it, which are called Schiffner's dots.
So summarize that. Falciparum equals banana-shaped hematocytes, multiple rings, normal-sized host cells. Vivax equals enlarged host cells covered in pink Schiffner's dots. What about Plasmodium malaria?
Malaria is sort of the old man of the group. It strongly prefers to infect older senescent red blood cells, which are smaller. The classic diagnostic sign for malaria is the band form. As the trophozoite grows inside the cell, it stretches straight across the middle of the red cell like a thick rectangular sash or a belt.
It seems so distinct when you describe the shapes out loud like this, but actually looking down a scope, it must be really tough.
It's a true art form. It takes years of daily practice to master it. And just to completely ruin your day in the lab, there are other parasites in the blood that mimic malaria, like Babesia.
Right, Babesia microdentocet fever. Transmitted by the ixodes tick in the northeast U.S., not by mosquito.
Exactly. Under the microscope, Babesia ring forms look almost exactly like early malaria rings, small purple circles inside the red cell. But Babesia has a very specific replication trick. It occasionally forms tetrads, 4 distinct rings arranged together in a perfect cross shape. It is universally called the Maltese cross. If you see that cross on a blood smear, it is 100% Babesia. And of course, clinically, your history would point to tick bites in Martha's Vineyard or Long Island, not a recent safari in sub-Saharan Africa.
And trypanosomes. Are they inside the red blood cells too?
No. Trypanosomes, which cause Chagas disease in the Americas or African sleeping sickness, are extracellular blood parasites. You do not look inside the red cell, you look in the plasma space right between them. They are large, very distinct worm-like structures with a long, undulating membrane and a flagellum, literally swimming freely through the plasma. In a fresh, wet amount of blood, you can actually see them violently thrashing around, bumping into the red blood cells. They're pretty hard to miss if you're actually looking for them.
Moving on to section 6, urine, sputum, and skin. Who even knew parasites could be in all these places? Let's start with urine.
The massive target here is Schistosoma hematobium. This is a trematode, a blood fluke. And it has a bizarre evolutionary predilection for the venous plexus, the network of veins directly surrounding the human bladder.
But if it lives inside the veins, how do the eggs get into the urine inside the bladder?
The female worm lives in the vein and lays eggs. Now, these eggs have a very distinct terminal spine, a little sharp, rigid spike right at the bottom pole. The eggs literally use that physical spike combined with some caustic enzymatic secretions to slowly punch and tear their way through the vein wall, through the muscular bladder wall, until they pop out and fall directly into the bladder lumen to be excreted in the urine.
Good Lord, that sounds incredibly painful. It causes hematuria, right? Blood in the urine.
Yes, classic painless or painful terminal hematuria. Now, is there a trick to collecting this urine sample? Because it's not a standard cup.
Yeah. How do we catch it?
The eggs are heavy and sticky. They don't just float freely in the urine pool. They often settle and get densely trapped in the mucus and inflammatory pus right at the base of the bladder trigone. They are really only expelled efficiently at the very, very end of urination, as the bladder muscle squeezes down tight. So you must explicitly instruct the patient to collect the very last few drops of voided urine.
So definitely not the clean catch midstream sample we always use for bacteria UTIs.
Exactly the opposite. You want the terminal urine. And here comes our old friend, the biological clock again. Peak excretion of these eggs is tightly tied to host activity and is often highest right around midday, between 10 a.m. and 2 p.m. So you want a noon collection, last drops only.
Let's talk about sputum next. When I think sputum sample, I immediately think of ruling out tuberculosis. But parasites.
The classic one is Paragonymous westermani, the oriental lung fluke. Humans usually get it from eating raw or undercooked freshwater crabs or crayfish. The adult worm actually lives in the lungs and forms a fibrotic cavity there. When the patient coughs, the microscopic eggs get pushed up the bronchi and come out in the sputum. Clinically, it can perfectly mimic TB on a chest x-ray, coughing, cavitary lesions, night sweats. The sputum is often classically described as rusty or dark blood-tinged because of the worm damage.
And we mentioned strongyloids earlier. Does that end up in the sputum too?
Yes, in a terrifying scenario called hyperinfection syndrome. This usually happens when a patient with a chronic, low-level strongyloids infection is suddenly given high-dose systemic steroids, maybe for asthma or an autoimmune disease. The immune suppression allows the internal autoinfection cycle to go into hyperdrive. The strongyloids larvae multiply uncontrollably and migrate en masse through the lungs. You can actually find the live larvae violently wriggling in a fresh sputum sample.
Oh, absolute nightmare fuel. Steroids plus strongyloids equals disaster. Finally, skin. What are we looking for in the skin?
This is primarily for Onchocerca volvulus, which is the nematode that causes river blindness in Africa. The adult worms live tangled up in these hard subcutaneous nodules, literal lumps, right under the skin.
So do you just take a scalpel and biopsy the lump?
You can, but that requires minor surgery. The much easier diagnostic test is called the skin snip. The adult female inside that nodule continuously releases millions of tiny microfilaria. These don't go into the blood. They migrate directly through the dermis, the upper layers of the skin, causing incredibly intense, maddening itching. The clinician takes a tiny superficial slice of skin, trying to make it completely bloodless if possible, just epidermis and upper dermis, puts it in a drop of warm saline on a glass slide, and waits.
What exactly are they waiting for?
It is a motility test.
Yeah.
You literally sit and watch under the microscope for the live microfilaria to actively swim out of the skin tissue fragment and emerge into the surrounding saline pool. It's a real-time observation.
That is incredibly vivid. Okay, moving into section 7, we're finally stepping away from the microscope, the modern shift to immunology and molecular testing.
Yes, this is the paradigm shift from visually hunting for the organism to chemically detecting it. We basically have two main arms here, antigen detection and antibody detection, and they are very, very different clinical tools.
Let's start with antigen detection.
Antigen tests look for actual physical pieces of the parasite itself, specific shed proteins or cell wall structures. If an antigen test is positive, it means the parasite is physically in the patient's body right now. It strongly represents an active, current infection.
And this is rapidly becoming the gold standard for things like Giardia and crypto, right?
Absolutely. The enzyme immunoassays, the EIAs for Giardia and Cryptosporidium in stool are fantastic. They are significantly more sensitive than a human looking through a microscope. They don't require an expert parasitologist with 20 years of experience to read them, and they are incredibly fast. It gives the doctor a simple yes or no answer.
Sounds perfect. What's the downside? Why not use it for everything?
The downside is that the yes or no answer is exclusively specific to that one single bug you tested for. If you run a Giardia-specific antigen test, it will accurately tell you if Giardia is there. But if the patient actually has a hookworm infection or a pork tapeworm, the Giardia test just comes back negative, and you completely miss the real diagnosis. Microscopy, for all its faults, casts a very wide net. You can see whatever happens to be swimming by. Antigen tests are a highly targeted sniper rifle. You only hit what you are aiming at.
Got it. Then we have antibody detection, which is serology, testing the blood for IgG or IgM.
Right. This detects the human body's immune response to the parasite, not the parasite itself. The fundamental glaring flaw with using serology in parasitology is immune longevity. Human antibodies to parasites tend to stick around in the blood for years, sometimes decades after the infection is completely gone.
So a positive antibody test is essentially a historical footprint, not necessarily a current diagnosis.
Very often, yes. If an adult from an endemic area has a positive IgG for malaria, it might just mean you were bitten by an infected mosquito when you were a teenager. It does not prove that the fever you have today is malaria. However, despite that flaw, serology is absolutely invaluable for invasive tissue infections.
Why is it so useful there?
Because you simply cannot always safely get a physical sample of the tissue. Take cysticercosis as the prime example. This is when the larvae of Taenia solium, the pork tapeworm, form cysts directly inside the human brain tissue. It causes severe onset seizures. You absolutely do not want to blindly stick a needle into someone's brain just to get a diagnostic sample if you can avoid it.
Definitely not.
So instead, you test the patient's serum or cerebrospinal fluid for antibodies. If the patient has new onset seizures, brain calcifications on a CT scan, and highly elevated antibodies to Taenia solium, that combined picture is your definitive diagnosis. It acts as a safe surrogate for a surgical biopsy. The exact same logic applies to Echinococcus hydatid cysts deep in the liver or toxoplasmosis lesions in the retina of the eye. You test the blood because the tissue is untouchable.
That makes perfect clinical sense. And then, of course, there is the absolute frontier of modern diagnostics, molecular testing, specifically PCR.
PCR is a total game changer for raw sensitivity. It amplifies DNA, so it can theoretically detect a single DNA copy of a parasite in a sample. And it doesn't care if the organism is dead, alive, or chopped into pieces. But there's a massive logistical trap here that Murray explicitly points out, and clinicians fall into it constantly.
The fixative trap.
Exactly. Remember, way back in Section 2, we explicitly said, put the liquid stool immediately into formalin or PVA to preserve the delicate cell structure for the microscope.
Right. Stop the trophozoites from rounding up and dying.
Well, formalin works chemically by heavily cross-linking and denaturing proteins. That process aggressively fragments and damages nucleic acids. It destroys DNA, and it completely inhibits the Taq polymerase enzyme that is required to run a PCR reaction. If you take that lovingly formalin-preserved stool sample and send it down to the molecular lab for a PCR panel, you will get a false negative, or the machine will just error out and the lab will reject the sample.
So if you want PCR, you need a completely different bucket.
Yes, you absolutely need unpreserved fresh stool, quickly frozen stool, or you have to use a much newer, specialized preservative like Carrie Blair or Total Fix that is specifically engineered to be compatible with DNA extraction. The clinician has to consciously decide before they even hand the cup to the patient, am I sending this to be looked at under a microscope, or am I sending this to have its DNA sequenced? You can't usually use the same cup for both.
Okay, Section 8. Culture and xenodiagnosis. Now, in the bacteriology lab, we culture everything: strep throat, urine, blood. Why are we not routinely culturing parasites?
Honestly, it's just entirely too hard. Bacteria are relatively simple organisms. You give them some basic sugar, some salt, and body warmth, and they will happily divide in a plastic dish. Parasites are complex eukaryotic animals. They have wildly complex life cycles. They often strictly require living host cells to feed on. Now, a few can be cultured. Entamoeba histolytica, Trichomonas vaginalis, and Leishmania can be grown, but it requires highly specialized, expensive liquid media and deep technician expertise. It is incredibly slow. So it's mostly reserved for academic research or very complex reference lab cases, not for routine daily hospital diagnosis.
And xenodiagnosis, I feel like this is a bizarre historical curiosity, but Murray explicitly includes it in the text.
It is totally fascinating from a biological perspective. It was historically used primarily for diagnosing Chagas disease, caused by Trypanosoma cruzi down in South America. In the chronic late phase of Chagas disease, the patient develops severe heart failure, but the actual parasites circulating in the peripheral blood are so incredibly scarce that you will almost never see them on a standard stain slide.
So if you can't see them, and PCR didn't exist yet, how do they find them?
They used nature's own biological amplifier. They would take a laboratory-raised reduvid bug, the kissing bug vector, that they knew for a fact was uninfected and clean. They would literally strap a small mesh container of these live bugs directly onto the suspected patient's forearm and let the bugs feed on the patient's blood.
Wait, they let the bugs bite the patient on purpose?
Yes, intentionally. The kissing bugs take a large blood meal. If there is even one or two microscopic trypanosomes in that entire volume of sucked blood, the parasite will find itself in the bug's gut, its natural multiplying environment. It will rapidly replicate into millions. A few weeks later, the lab tech dissects the bug or squeezes out its feces and looks at that under the microscope. If the bug is now heavily positive, it proves the patient is positive.
That is literally using the insect vector as a living test tube. That is absolutely wild.
It is brilliant. It's rarely done clinically today now that we have high sensitivity PCR, but it perfectly illustrates the deep connection between diagnostic medicine and vector biology.
Okay, we have systematically built the mental model. We have covered the Holy Trinity, the crucial life cycle clock, the rigid rule of 3 for stool collection, the malaria thick-thin protocol, and all the modern molecular alternatives.
I think we have thoroughly mapped the territory.
Now it is time to formally test the listener. Section 9, rapid-fire recall. I'm going to throw out a clinical scenario. I want you to give the listener a brief pause to lock in their answer, and then provide the correct answer and the biological why. Ready?
I'm ready. Let's do it.
Question 1. A frantic parent brings in a young child strongly suspected of having pinworm. You confidently order a standard stool O and P exam. Why is this the completely wrong test?
Let's give you a second to think about that.
I don't know. Why is the stool test wrong?
The answer is that pinworm eggs, and Urobius formicularis, are actively laid on the external perianal skin folds, not deposited inside the intestinal lumen. Therefore, they do not reliably appear in the regular stool stream. You absolutely must use the cellophane tape test or an anal swab in the early morning to manually collect the eggs directly from the skin surface.
Question 2. You have a severely febrile patient returning from a trip to Nigeria. You highly suspect malaria. You order only a thick film. What is the specific clinical risk of this order?
Take a moment to think about the difference between the films.
Okay. What is the risk of only getting the thick film?
The answer is that while your detection sensitivity is very high, you risk completely missing the species identification. The thick film intentionally aliases all the red blood cells, which distorts the parasite morphology. You must also have the thin film to differentiate Plasmodium falciparum, which is a deadly medical emergency requiring immediate specific therapy from Plasmodium vivax or oval.
Question 3. An organ transplant patient is heavily immunocompromised, and you suspect a strongyloids hyperinfection. What specific morphological form of the parasite do you instruct the lab to look for in the stool?
Think about the life cycle.
What are we looking for?
You must look for larvae, specifically the rhabditiform larvae. Unlike ascaris or hookworm, strongyloids eggs hatch deep within the human intestinal mucosal wall, so the actively swimming larvae are what actually pass out in the feces. If the tech only scans for oval eggs, they will miss the infection entirely.
Question 4. Interventional radiology is performing a guided aspiration of a large liver abscess, strongly suspected to be amoebiasis from E. histolytica. The fluid draining from the very center of the abscess is described as necrotic anchovy paste. Where specifically should the radiologist aspirate next to actually find the organism?
Lock in your answer.
Where do they put the needle?
The answer is they must aspirate the margin, the outer capsule wall of the abscess. The central anchovy paste contains only dead cellular debris and ghosts. The living, actively multiplying E. histolytica trophozoites are located entirely at the periphery, actively invading and consuming the healthy liver tissue.
Question 5. A patient complains of chronic foul-smelling diarrhea after a camping trip. A single stool O&P sample comes back negative. Why is this single test insufficient to definitively rule out Giardia?
Think about the math we discussed.
Why isn't one enough?
The answer is intermittent shedding. Intestinal parasites are not shed uniformly in every single bowel movement. Statistical data firmly shows that one single sample detects only about 71% of actual cases. You rigidly need 3 separate specimens collected over approximately 10 days to push that diagnostic sensitivity closer to 100%.
Question 6. To successfully find Wuchereria bancrofti microfilaria circulating in a patient's blood, what specific time of day must you draw the blood sample?
Think about the vector clock.
When do we draw the blood?
The answer is at night. Specifically between 10 p.m. and 4 a.m., Wuchereria bancrofti exhibits strict nocturnal periodicity to perfectly match the feeding habits of its nighttime mosquito vector. A standard daytime blood draw will almost certainly be a false negative.
Excellent. I genuinely hope you all got those right at home.
Those are the absolute core, non-negotiable concepts. If you fully own those mechanisms, you own the entire Murray chapter.
So bringing it all home to wrap up, what is the single biggest takeaway from this deep dive?
Diagnostics in parasitology is purely a function of biology. It is not just about having a really expensive, good microscope. It's about deeply knowing the life cycle. If you know exactly where the parasite is it in the gut lumen, the bowel wall, or the blood, and if you know when it is there, night versus day, then you can logically choose the right test. If you ignore the underlying biology, you will miss the diagnosis.
And as we close out, here's a provocative thought for you to chew on this week.
We are moving incredibly rapidly toward molecular syndromic panels. A single PCR swab that tests for 20 different parasites all at once. It's fast, it is insanely sensitive, and it honestly requires far less technical skill from the lab worker. But as we inevitably lose the true art of visual manual microscopy, what exactly do we lose as a medical community?
What do you mean by that?
Think about it. A pre-programmed PCR panel only ever finds exactly what it is explicitly programmed to look for. If a patient comes back from a remote jungle in a different country with a rare, totally unexpected parasite that simply isn't on that commercial 20-target panel, the expensive machine will just confidently print out negative. But the human eye, a curious, well-trained microscopist, would look at that strange slide and say, wait a minute, that doesn't belong here. What is that?
The machine only sees the programmed data. The human mind sees the anomaly.
Exactly right. We must be incredibly careful not to let our shiny new automated tools completely blind us to the unexpected biology that's still out there.
That is a perfect place to leave it. For your exam prep, definitely check out Table 70.1 in Murray for the absolute master list of all these specimen options. Thanks for joining us for this deep dive.
Keep looking closely.